have a friend who's a labor economist who breaks down the world into two types of problems: those that money can fix, and those that all the money in the world can't solve. Let's say you total your car and no one's hurt. You might be sad, frustrated with yourself, but with enough money, you can pay for car repairs or just get a new one. But if you have an illness that leaves you with a disability, or you're estranged from someone you love, or your kid's getting bullied in school, no amount of money can make those problems go away. And though I could spend all day talking about emotions, I also think this is a really useful framework to think about the challenges we face in primary care. Almost everyone I interviewed about primary care emphasized two things. First, the need to invest more money in primary care, which currently receives only about 5% of every healthcare dollar. And second, and more specifically, the need to address the payment disparities that have been institutionalized by the Relative Value Scale Update Committee, also known as the RUC, which we'll be talking about today. But let's just hypothetically assume that every state doubles its investment in primary care. And let's also assume we either abandon the RUC or significantly increase reimbursements for common primary care services. Would these changes address primary care's challenges? Probably many of them. You'd certainly have more resources to support behavioral health, social work, nutritional needs, the types of services that no one clinician can offer alone. And if revenue increased, it could possibly offset the overhead costs that have made independent practices so difficult to maintain. But the reason I'm not totally convinced that money's primary care is panacea is partly because of some of the other factors that have kept that money from primary care in the first place. Professional hierarchy, values, cultural norms, and the powerful inertia baked into our institutions. Will health systems, for instance, stop replacing well-trained internists with advanced practice practitioners who are less expensive to employ? Will the possibility of higher salaries attract trainees who'd otherwise have chosen careers in subspecialty care? And if we move away from fee-for-service, which many believe is the root ill of primary care, will the primary care system really be better equipped to meet the complex care needs of our aging population? Or will our system still be fragmented, heavily dependent on specialists, and even more oriented toward a set of population health metrics that may not reflect what's most important to our patients? I don't know, but that's what we're going to be talking about today: money. I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Our first guest is William Hsiao, an economist and professor at the Harvard School of Public Health. Professor Hsiao, who goes by Bill, is 90 years old and still consults internationally on physician reimbursement. And in the 1980s, Bill was chosen by Congress to develop the methodology that now helps form the basis of Medicare's physician fee schedule. And once Bill and his team came up with this methodology, the American Medical Association successfully lobbied Congress to allow it, the AMA, to oversee the payment updates. The resultant Relative Value Scale Update Committee, also known as the RUC, was formed in 1991. A few things to know off the bat about the RUC. First, the fee schedule is budget neutral. One specialty's gain is another's loss. Second, CMS generally follows the RUC's recommendations. And third, CMS's reimbursement rates are often used as a benchmark for commercial insurers. With billions of dollars flowing through the RUC's decisions, it's probably not surprising that the RUC has been called the most important healthcare committee you've never heard of. So to understand the RUC's origin story, it's helpful to know what was going on in the 1980s when Bill's study was commissioned. Basically, at that time, physicians set their own fees, a certain proportion of which insurers would cover. And under this usual and prevailing approach, large income disparities were emerging between specialties. And these disparities were driving an increasing sense of unfairness among some disciplines, and even sometimes a refusal to work with one another. Here's Bill describing his interaction with the chief of surgery.
I had the chief surgeon tell me that he told his residents, you do not have to cover the cardiovascular service because they are earning so much money they can hire their own doctors to do 24/7 duty. We will only go into these wards to do learning, but you don't have to do any service to these patients.
The surgeon's complaint highlighted a trend that Bill had been observing. Medicine's hierarchy was reflected in the prices that physicians charged.
When I started working on the set developing a new method to paying physicians, I discovered medical profession is one of the most hierarchical ordered professional. Who is on top? Who is in the middle? Who is on the bottom? The bottom was pediatricians and family physicians and also sometimes psychiatrists. The top are the newest surgery specialties.
Given this hierarchy, the frustrated general surgeon was hardly alone in resenting the unjust reimbursement structure. Why, for instance, could ophthalmologists still charge rates for cataract surgery that didn't account for the advances in anesthesia that had decreased the procedure's duration and risk? And why, despite the centrality of primary care to a well-functioning healthcare system, were specialists paid so much more than generalists? To be clear, as an economist, Bill found parts of the pricing structure rational. For instance, it made sense to pay cardiologists less for managing a patient's hypertension than for placing a stent during the throes of a myocardial infarction. But the relative value of many physician services was less clear-cut. Economists generally believe that the price of any good should reflect the cost of its inputs. In the case of medicine, overhead costs, years of training, and the amount of work performed. But what actually is the amount of work when the cognitive, technical, physical, and emotional demands of any given service vary widely? In other words, could they place an objective value on what is otherwise a subjective determination?
I'm sorry to say this, medicine is not a pure science. Medicine is 50-60% science. Rest is use your knowledge making judgments. Medicine doesn't know everything. So physicians tell us the most stressful part of their work is they are not sure what is the causation of this condition. They have to may spend more time, order more tests. However, at the end, they're still unsure. That's when they use the word, I have sweat on my brow. And they say, that's a very important part of my service, my input.
The sweat on the brow aspect, though tough to measure, actually seems reasonable to me. When I think about my interventional colleagues, for instance, who are tasked at all hours to intervene on patients who are literally on the brink of death, it makes total sense to me that the stakes they face are higher than if I were to round on similar patients, once stabilized, a few days later, and write some notes. In other words, I'd be a lot more sweaty in their shoes. But whether we're talking about the placement of mechanical support for a patient in shock or a routine visit for diabetes management, there are countless physician services that Bill and his team had to score. And so they spent a year and a half interviewing physicians across specialties, developing a relative score for common procedures and services, and then trying to get consensus between specialties, especially if their services overlapped.
So every specialty, we try to actually identify a dozen common procedures or services, different kind of patients, and trying to measure their relative effort, mental or technical or iatrogenic harm efforts. Let's say with a surgeon, a general surgeon and the orthopedic surgeon, amputation at the knee. So they would describe to each other. That's why they came in to meet for a day and a half. We bring three specialties together to provide check and balance. We're not just taking that specialty's words. they will challenge you, or let me just say it, the most common thing I hear from lower hierarchical specialists say to the upper ones, oh, come on, Joe, it's not that complicated like you say. You're describing an exceptional patient. The typical patient, we know you do this and that. Then they will argue, and then they will come to a consensus. Then we can say orthopedic surgeons say amputation of the lower leg on my scale is 3. But in general surgeons, that's a 4. We were able to find these linkages across all specialties. But I'll confess, a great deal of this is quantitative, but a lot of it is actually is qualitative judgment.
Bill and his team build as much rigor into the process as possible. They survey hundreds of physicians, perform these cross-linkages that he just described, and even after they get buy-in from clinicians, Bill has to prove to his economist colleagues, who are dubious given the qualitative elements, that the method is sufficiently objective. So a 2-day conference is held where Bill presents to the economists. So you take 3 years, you go up in front of all your colleagues. Were you stressed? Like, did you get stressed about this, or are you very even-keeled? You seem even-keeled.
My lung literally broke out in the final stage.
Your lung?
Half my lung just
collapsed?
Collapsed.
A pneumothorax?
Yes.
Oh, so you were really stressed.
Oh, yes.
So now you are the picture of Zen, but not then.
No. But it's the pressure, the timing, the Congress want the answer. But the greatest stress actually at that time is after we get a consensus, we feel we got a physician's review. We have to publish articles in the most prestigious journals to have the scientific review, not just a consultancy.
The stress doesn't end, though, once they publish their results.
Well, when Congress was adopting, I was called in by the assistant to the president and told me this was the first Bush presidency. And President Bush is against this project anyway, because this interfered with the free market price setting. But Congress commissioned this study, and you have done a job, okay. But we don't want you involved anymore. AMA is going to take over the updating. I was taken by surprise. You let the fox got in the chicken coop then.
Bill thought the process would be overseen by the government or an academic outfit.
But instead they said, we're going to give this to AMA. The reason gave to me was, 1, the government doesn't want to be in the middle of this. 2, AMA will pay for it, so there won't be any expense to the government. I still remember those 2 methods. And then they told me if I fight it, they would chop me off on my knees.
Seriously?
Oh, yes.
Oh, God. So you didn't fight. Having a more neutral body oversee the update process might have been preferable, but Bill's also the first to admit that the methodology they created isn't perfect.
It's a very controversial, both methodologically, theoretically, and the data. And I admit we did not achieve 100%. We may achieve 60%, hopefully 65%. But to me, as an academic, I need to be honest.
For a few years, at least, the income disparities between proceduralists and non-proceduralists decreased. And then for lots of reasons, some beyond the scope of this episode and some, honestly, beyond the scope of my own understanding, income disparities widened again. Critics of the RUC have described many of its limitations. But when it comes to increasing parity between primary care specialties and everyone else, the criticism I heard most often had to do with primary care's inadequate representation. Of the 32 voting members on the RUC, only 5 represent primary care fields, while the rest typically represent specialties. And one consequence of this is that the definition of work intensity just hasn't evolved to reflect either the complexity of patients' conditions or the amount of uncompensated work PCPs do. One 2013 analysis, for instance, found that a specialist performing either cataract surgery or colonoscopy generates more revenue in 1 to 2 hours than a PCP generates in a full day of caring for Medicare patients with complex conditions. And in the 12 years since those data were published, the amount of uncompensated work expected of PCPs has only grown. To be clear, primary care isn't the only field disadvantaged by the reimbursement disparities between the cognitive and procedural. Infectious disease physicians, for example, are among the lowest paid among us, and we all know how much we depend upon them, not just to treat infections and get us through the occasional pandemic, but also to actually read and often beautifully summarize a patient's chart. And yet, for all we lament the RUC's role in undervaluing cognitive services, it's also not obvious that increasing reimbursement for these services will mitigate payment disparities. Hannah Naprosh is a health economist at the University of Minnesota. Her expertise is wide-ranging, so you're going to hear from her more later. But Hannah's done some work examining what happens when you increase reimbursement for evaluation and management services, which is essentially how we bill for cognitive work. Hannah's best friend is a primary care doctor, which is how she got the memo about this potential pay increase in 2021.
So this is a long-standing, well-established problem, right? In medicine, especially in Medicare payment, which filters through to commercial payment to basically every other, the way we structure the reimbursement for healthcare services, Medicare is the dominant player there. And Medicare has historically paid far less for cognitive services compared to procedural ones. You'll notice I haven't said primary care yet, but the connection there is pretty tight because in primary care, it's going to be almost entirely, if not totally, cognitive services. So in 2021, and it's funny because I heard about this from aforementioned best friend when she said, oh my gosh, they're raising the E&M rates. And I went, I looked at it, and indeed, in 2021, Medicare increased the payments substantially for evaluation and management services, the bread and butter of primary care. The expectation, I don't want to say the goal because that assumes I know what Medicare is trying to do. The expectation of many was that this would shrink the reimbursement gap between primary care and specialty care. And of course, that filters through to income because a lot of salaries are based at least partially on productivity. I don't have to tell you that, right? Like, it's not eat what you kill, but that typically is part of somebody's compensation. So the idea was it could shrink the gap between primary care and specialty income at the end of the day. And hopefully, eventually, that will make it more attractive to go into primary care because this type of cognitive service is more rewarded. Everybody took a haircut. My mother-in-law is a diagnostic radiologist. So I also heard about it from my mother-in-law because everything else that wasn't evaluation and management took a small cut, right? But that meant a fairly big cut for radiology. They were actually some of the biggest losers of this policy. The expectation was that it would shrink the pay gap between primary and specialty care. What actually happened was as close to nothing as you can get, unfortunately. And there were two problems. The first problem was that evaluation and management is something that primary care does a lot, but so do other specialties.
Okay. Like me, rheumatologists, endocrinologists, we all do a lot of thinking kind of things.
Exactly. So everybody got that bump. The other problem, at the same time that Medicare increased the payment rate, they also tried to take away some of the documentation requirements, effectively making it so that you could qualify for a higher intensity E&M code, which gets you more cash at the end of the day. You had to know about that to take advantage of it. And the specialties that took advantage of that change in coding were not primary care specialties.
Who were they?
I don't want to throw anyone under the bus.
No, it's okay. Throw me under the bus. Was it cardiologist?
No, you were not the worst by any means. Cardiologists did take advantage. Everybody took advantage of it, right? Like average intensity of E&M services just jumped immediately.
Who took the most advantage?
Ophthalmology was really high up there.
Wait, I'm so confused. Don't they already get all the procedural revenue? But then they just are like really good at figuring out how to code for level of intensity. Yeah. Okay. So you don't want to speculate on Medicare's intent, but let's just pretend that the goal was to increase parity within the profession. What you're saying is that everybody took advantage of it, and primary care, if anything, took advantage of it less.
Exactly.
Do you think that's because they're so busy, they just didn't even have time to hear about it?
I do. That's my theory. It's based on no data whatsoever, but that's my guess, right? Their plates are so full that to, optimize the way they code is maybe not the first priority when they wake up in the morning.
I'll say two things about this. The first is that when we talk about increasing primary care reimbursement, a lot of primary care doctors aren't looking to increase their own salaries. Most want primary care to be better resourced. But I started noticing in my interviews, some primary care doctors would wince when I'd suggest that paying them more would fix primary care's problems. These doctors would rather see dollars directed toward other support services to help better meet their patients' needs. The second thing, though, that this example suggests is that addressing payment disparities through a fee-for-service system may just be impossible, which is one of the many reasons why a lot of health policy experts believe that we should abandon fee-for-service billing for primary care and move toward a value-based payment system. Troy Brennan is one such expert who just wrote a book about primary care, aptly titled Wonderful and Broken. Troy is an internist and health services researcher who's held leadership roles at academic medical centers, insurance companies, and industry, including most recently as the chief medical officer at CVS Health. Troy, alongside many experts, argues that the best healthcare systems in the world all rely on a strong foundation of primary care. So Troy traveled all over the country talking to primary care physicians who were thriving so that he could better understand what it would take to build a more sustainable primary care system.
Well, I think you have to do two things really. One is that you have to make sure that its focus is value-based care, that the primary care doctor is being incentivized, is being paid to ensure the patient's health is good and help the individual make choices that are smart choices from the point of view of a cost-effective healthcare system. So you need those incentives in place, and you need to pay people more to do it. As you know, primary care is grossly underpaid, probably half to a third of what other specialties are paid. And you're simply not going to get the right people and get the right resources surrounding those people unless you put more resources into it. I think that primary care today absorbs something like 35% of the visits and about 5% of the funds in healthcare. So you get a sense from that about how it has been undervalued for years. That undervaluing is really the result of fee for service and our focus on technology and procedures and high pay associated with those technology and procedures and high pay associated with those specialties. But it's a matter, I think, of our healthcare system not understanding the role primary care should play more so than it is a really conscious decision to drive down primary care.
So when you talk about value-based care, I want to understand better what it looks like, because I think when I first learned about value-based care, it seemed to me that we needed to be measuring a lot of things to make sure that people were achieving the value that we were paying for. So it felt a lot like pay for performance, which didn't seem to work, and it created a lot of unintended consequences that people were just focused on the measures and also wasn't clearly actually improving outcomes. So can you distinguish between how you envision value-based care and my conceptualization, which I assume at this point is now wrong?
Yes, I think you're right. I mean, there is a sort of strong tone of value-based care, which was sort of pay for performance. And we elaborated a whole series of quality measures over the course of the 1980s and 1990s. And then we paid people to sort of meet those quality measures. And the primary care doctor faced a welter of measures. I think measurement of quality is important, but I agree with the previous administration's CMMI, which advocated for a much pruned down series of quality measures, something like 15 to 18 key things that had to do with care for chronic disease. Value-based care, at least in my mind, as a sort of old timer, is another way to sort of say managed care. And primary care doctors and most doctors don't like to refer to managed care. But basically what you're doing is you're creating incentives for an individual physician, nurse practitioner, or physician assistant to help the patient understand what care they need and then guide that patient to services that are effective and do things that are effective in terms of health promotion and prevention that reduce overall costs.
Troy mentioned that one benefit of value-based payment design is the elimination of waste, since you get rid of the incentive to do unnecessary things. But my own impression, which I shared with Troy, was that the reason fee-for-service was so destructive to primary care had little to do with waste, but instead reflected the fact that without procedural volume, the only way for PCPs to generate more revenue was to see more patients. And that's how we landed at this 15-minute visit paradigm that's been so painful for both doctors and patients. And so I asked Troy how the value-based approach would address this time problem.
Yeah, I think you're exactly right. When I said, you need not only the sort of managed care mindset, but you also need more resources. And those resources might be better pay for the primary care providers, but they're more importantly, they're developing the resources they need, a team-based approach, because primary care, when it's done correct, is a team-based approach where there's nurses and case managers and pharmacists and nurse practitioners and physicians all working together. And in the book I wrote, I take a tour through a number of sites that are doing exactly that and getting really great results as a result. So in many ways, I shared some of the same concerns you did. Can this actually work? But when you see places where it does work, you realize that they're getting much better outcomes than what we're seeing with the average primary care provider. But in a fee-for-service system, you're exactly right. The only way fee-for-service a primary care doctor can make more money is to see more patients. So they drive more patients through, and they don't do the essential health promotion, prevention, and consideration of the needs of the patient that are necessary in order to have a real value-based approach.
One clinic Troy visited that successfully implemented this approach is run by South Central Foundation and is located in Anchorage, Alaska.
They had a patient they told me about who had been in the hospital 40 or 50 times in the last 2 years and had been absorbing sort of huge resources. But the patient was coming out of a fee-for-service approach where there wasn't any primary care doctor or nurse practitioner trying to sort of direct the ship, as it were. And what they did was they elaborated a whole series of community resources, home visits, visits with pharmacists. They had a case manager or two who were assigned. All of that's a lot less expensive than have the patient spend any time in the hospital. And they were able to eliminate these hospitalizations. So the patient had been at home for the last year and a half doing quite well. In the fee-for-service program, everyone just does what they do and no one considers what resources are being elaborated on behalf of the patient. In a capitated approach, which is essentially a value-based approach, everyone has to consider what those resources are and what's the most effective way to take care of patients. It turns out it's much better quality for a patient to be able to sort of spend all that time at home rather than popping back and forth into the hospital.
Were those doctors happy?
Oh, they're very happy. They're gratified by their work. I talked to a doctor at South Central, for example, who had worked at another tribal setting in the Southwestern United States, which was completely sort of fee for service. And he was working 60 hours a week. And he felt as though he was just treading water, that there was no way he was going to be able to help make his patients better because he was stuck in fee for service. And he came to South Central. He gave the example of diabetes. They had actually started a dialysis clinic at this tribal practice he was in the Southwestern United States because they had so many patients who had diabetes who were losing function in their kidneys. He came to South Central, and it's basically unheard of. People's diabetes is managed carefully, and there isn't any kidney dysfunction. So, he found a complete turnaround. And that kind of thing, when you see that, when your patients are remaining healthy, you become a big advocate for this kind of care.
I really don't know whether a value-based payment design will prove as transformative to primary care as some may hope. I certainly don't think they will, though, if they're not accompanied by directing more healthcare dollars toward primary care. But even if we do allocate more money toward primary care, listening to Bill discuss our long-entrenched cultural challenges made me wonder, again, about the relationship between reimbursement and social hierarchy. Meaning, does the respect follow the money or vice versa?
For example, let's just take even people in a similar specialty. I bring in, let's say, cardiologists, internists, along with cardiovascular surgeons to talk about cardiovascular surgery because cardiologists know something about the heart and the pulmonary function. And also anesthesiologists because they can observe what the surgeons do in the OR room. Well, you can see that hierarchical order plays out. Cardiovascular surgeons just don't pay much attention to cardiologists, even less to anesthesiologists. And they have to be more polite when they speak up.
It's so true. And it's so interesting to hear from your perspective, not having come up through medical school and, residency training, and that pecking order manifests in all of our interactions. And it's always striking to me actually how little we talk about it. But I think you immediately seized upon the most important and relevant point to all of us, which is that we're looking to family medicine, primary care to coordinate care. And for patients who have multiple specialty involvement, if they're unwilling to engage with the primary care doctor, it makes that primary care doctor's job so much harder.
You are absolutely right. If you don't respect another specialist that much, you do not actually try to get information from them. You say, I know more than you do. And also, they don't necessarily send the information back to the family physicians. By the way, that's the case throughout the world I work in.
So this is a very important question then, because one thing I've wondered a lot is if we just pay primary care doctors more, will the respect follow? And what you're saying, because it sounds like there are countries that are more equitable, it doesn't necessarily mean that respect then follows to primary care. Is that true?
The only exception is England. And what I'm just described to you is because I still work in China. And China is trying to develop family physician. It's the lowest specialty on the totem pole. And the specialists just don't give them information, and they say, you are not qualified as a gatekeeper, for example. And you don't know enough about my specialty. Usually that's the reply. Except the specialists refuse to recognize they only specialize in one part of our body or one disease. They don't have the comprehensive knowledge. Now here, let me give you why I respect England. But England was an accident of history. Their GPs were independent practice. Their specialists are hospital-based, salaried. Their compensation about equal before World War II. When Bevan established national health insurance in 1948, the GPs were organized. They say we have to have parity in pay with the specialists. Second, National Health Service in England say GP will be the gatekeeper. Consequently, specialists depends on the GPs for referrals. They have to be kind to the GPs to convince GPs, I know something really you may not be able to handle. Let me tell you the latest though. The latest in England is just the reverse now. Reverse in this way. The specialists rely on the GPs to actually reduce their patient load. Patients still want to see the specialists because they have more information. The specialists, which are hospital-based, are so overloaded, they are very kind to the GPs to say, okay, you have to block this kind of patients. Come to me directly.
I told Bill that his observation was consistent with my own experience. When you have hospital-based salaried doctors, there's very little incentive to do extra work. You see this all the time on consult services in academic medical centers, for instance. I like to believe we're all always doing what's best for patients. But if you're on a busy consult service, get no reward for seeing more patients, and in fact only add to your load when you agree to see someone, you can imagine there's a lot of consult blocking that goes on. Or even more subtle impulses, like it's so tempting when someone calls you about a patient's chest pain to suggest it sounds non-cardiac and get out of having to do any work. I feel like I'm constantly fighting this lazy impulse within myself. And I asked Bill whether it's a downside of any capitated system.
You're right. Again, I refer to what China actually is experimenting how to pay physicians. They are trying to shift in some pilot sites, salary the physicians, then some physicians, not all, then become laid back. Why should I try very hard? And when you assign me on extra hours, I give you all sorts of excuse. So what they have developed actually is use RBRVS as a bonus system. And these pilot sites pays 30% of physicians' compensation as bonuses. Then say how much work effort you have devoted to the patient care.
I like that hybrid that China is attempting. I also like how you said they're laid back as opposed to lazy, which is what I said. I do think humans are going to be human, and there are downsides to capitation, no matter the specialty. But when it comes to the culture of medicine and this chicken and egg matter of money and respect, one of my primary care doctor friends told me that maybe I've been over-indexing on the importance of respect in the first place. One of the things I love about this friend so much is that she knows what she's good at and she never tries to pretend otherwise. And in the context of being a primary care doctor, she knows she's an extraordinary generalist. As she told me in an exchange of voice memos, I'm really good at lots of things. And because of this, she doesn't care about respect or lack thereof from other disciplines. I heard a similar sentiment from Renee Critchlow, who's a family medicine physician and chief medical officer at Codman Square, a Boston FQHC. Renee, like Troy, emphasized the necessity of greater investment in primary care, practice redesign based upon value-based payment models, and team-based care. And what Renee said is that with these steps, which would allow primary care doctors to do their jobs more sustainably, what the rest of us think or don't think becomes irrelevant.
I don't need the presumed or feigned affection from people who don't understand primary care. I need them to get out of my fucking way, because if we can do our job, we demonstrate that we are critical. My abilities are going to demonstrate that we are valuable. So we get the framework, if we get the infrastructure that allows us to succeed, they'll acknowledge and understand that we are the basis, we are the foundation of a functional healthcare system.
I deeply believe that you cannot have a high-functioning healthcare system without a strong foundation of primary care. And to strengthen our primary care system, I do think we need a massive reallocation of healthcare dollars. But I also think that money, while necessary, is insufficient. There will always be resource constraints, and resource constraints force tough choices. So what does a strong primary care system even look like? And how should primary care doctors best spend their limited time?
I'm not taking care of someone with opioid use disorder. Because someone's here for physical, I'm not taking care of someone who has an immediate urgent infection. Because I'm here for a physical, someone who thinks they have COVID, I'm not able to take care of them. Or someone whose depression is much worse. Take your pick. All these things are not happening because I'm doing really marginal, if at all beneficial prevention. And by virtue of doing prevention, quote unquote, I'm not taking care of sick people.
I I'm Lisa Rosenbaum, and that's next time on Not Otherwise Specified, a podcast from the New England Journal of Medicine. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My new article series on primary care can be found at NEJM.org. I love hearing from you, so let me know what you think. Our email address is nos@nejm.org.